Afternoon, everybody. I'd like to say thanks very much to Sharon and the team in Ovacare for inviting me. I'm just going to go over, there's a few things here to talk about, so I'm going to go over a few of the interesting kind of background points and some little chat about screening and some of the surgeries that we do for ovarian cancer. Lifetime risk of ovarian cancer is 2%. Now, it doesn't seem very high, but it's a cumulative risk. So it means that 1 in every 50 people will get ovary cancer if they live long enough. And because it's a cumulative risk, it tends to be something that occurs later in life for the majority of people. It's the 7th most common cancer in women, if you count all different types, and it's the 2nd most common gynecological cancer. Cancer of the womb is the most common. But the big issue with it, as we all know, is that it's the most common cause of death in gynae cancer because the survival rates are lower than for some of the others. And the reason for that usually is because people present later in the course of their disease. Because, like I say to people, if your ovaries were on top of your head, you'd know that there was something wrong with them straight away. But because they're inside your tummy, they're not there, they're not visible. You can't feel them like you can feel the outside of your body. You don't have the nerves to feel them. So they can misbehave. And as a consequence of that, 80% of women present with late-stage disease. So we talk about in gynae cancer stage 1, 2, 3, 4. Stage 1 is in the thing. Stage 2 is beside the thing. Stage 3 is further away from the thing. And stage 4 is everywhere else. So unfortunately, it occurs that 80% of women come in with a late stage of diagnosis. So the corollary of that, of course, is that the earlier you detect it, the better you do, okay? Because no matter what treatments we have and no matter how successful they are, the less there is to treat in the first place, the better it is for the person involved. So if we look at the womb here, we've got the fallopian tubes, we have the ovaries, and this is kind of like the skin around it. It's called the peritoneum. Peritoneum is the skin inside your belly, just like your epidermis is the skin on the outside. And then the cervix is down here and the vagina below it. So if somebody has cancer on one or both ovaries but it isn't anywhere else, or if it's a tubal cancer, which is another variant of ovarian cancer, and if it's only just in the tube, your success rate's very high, and some people don't even need to have chemotherapy depending on the subtype of the cancer. If we see stage 2, it's in the area around the ovary. It might be on the womb or a little bit on the tubes or somewhere in the pelvis. And your survival is still pretty good. But when we start getting up into the tummy or into the lymph nodes, that's where the problem arises. And we often find them because the inside of the belly is just one big bag in which all of your bowels and your liver and your stomach and everything live. Cancer cells can travel around this and they can attach to any of the surfaces. And that's where the problem arises with the drop in survival. Because there's more of it, because it's widespread, it can be harder to treat. And when we talk about stage 4 then, if you're diagnosed when it's in your liver or in your lungs, then your survival rate's very low. Now, when we talk about these, we're talking about groups of people, of course. There's always people who do better, people who do worse. Una, for example, has done very well. She's been fighting the disease. It keeps coming back, but she's been keeping going with it. Whereas some people are less fortunate than that and they don't do as well. So what are the risk factors? Unfortunately, being white is a risk factor for some reason. Never being pregnant, never being on the pill, early onset of your menstrual cycle, so the younger you are when you have your first period, and the late menopause, so the longer you have your periods for. These are all risk factors which are related to the number of times you ovulate. If you ovulate, your ovary changes shape, it produces an egg, and it's active. And through various reasons, that can encourage the chance that some of the cells become abnormal. So when you're pregnant, your ovaries are quiet, they're not doing anything, they're kept under suppression. If you're on the pill, the same thing happens artificially because of the hormones you take. And if you have less periods in general, less activity of the ovary, your chances are lower of having a problem. Obviously, a family history is important, and then there's the genetic syndromes which very much increase the risk of problems. So, as Una was saying, about looking back and seeing these symptoms, and when you look back at them after a diagnosis, you can think, okay, well, God, you know, like if I'd have added all them up, I might have thought of something previously, or if someone had picked up on it. And that's why, you know, we have this horrible name for the silent killer, because people often have problems that are so subtle that they don't pin them down, or their doctors don't recognize them easily. And these would be the common ones. So swelling in the tummy, so your pants get a bit tight, and you wonder why you haven't been eating a lot of cake recently and the pants are still getting too snug. You feel nauseated. You have what we call early satiety, that you feel full earlier than you think you should, even after eating a small amount of food, or else you're losing weight despite eating. And then shortness of breath, which is dyspnea, and because of pressure on from the tummy pressing up on the chest. So there's been several studies looking at this, and they say that the majority of women have several months of symptoms before they get diagnosed, even when it's early, at an early stage. And the awareness, and this is a big issue, that the awareness of the potential for ovarian cancer isn't always there. So if we have an increased awareness of the possibility that these symptoms are potentially related to the ovary, then we can get onto things and hopefully diagnose things at an earlier stage. So things that improve that are early recourse to being reviewed by your doctor, having a vaginal examination, having early access to some kind of X-ray imaging, so ultrasound being the one that we use mostly, and getting your CA125 checked. So abdominal symptoms tend to be the most common ones, and this is the difference between having a bit of a sore belly because you've eaten something that doesn't agree with you, or something that could be related to ovarian cancer. It's the recurring nature of it. People who have things like irritable bowel symptoms or constipation tend to have pain a couple of times a month on average, whereas the average complaint for people with developing ovarian cancer is much more frequent. The discomfort tends to be more severe and progressive as well, and often multiple issues coming together. So feeling like you need to go to the toilet can be from pressure on the bladder or irritation of the nerves, bloating because of it's affecting your abdomen, you're affecting your bowels, and swelling because of fluid. So if we know that looking at things from and diagnosing things at an early stage is beneficial, how could we do that? We don't all, unfortunately, have access to doctors who are have their finger on the pulse in this regard. So is there anything else we could do? So we talk about screening. We know that there's good screening for breast cancer. We know there's good screening for cervical cancer. We know that there's good screening for bowel cancer, that you can have tests that predict the chance in the next few years, are you going to get a problem? The only issue is that we haven't had any success in screening for ovarian cancer over the last kind of 10, 20 years. What we want to do with a screening test is do a test that's accurate, that gives us an idea that something may be wrong, and that predicts the chance of a problem arising. Similarly, you want one that tells you if everything looks okay, that you will remain okay. And with ovarian cancer, the screening that we have is ultrasound and CA125. Now, this is separate from having an ultrasound or having your CA125 checked if you have symptoms. This is talking about just everybody goes for their test every couple of years. And they have found that screening for ovarian cancer doesn't reduce the death rate from ovarian cancer, but it actually can increase the risk of problems, that you end up taking out normal ovaries that look a bit funny. And the thing about the ovary is the ovary changes shape every month. It can there's a lot of benign things that can cause the ovary to look different. So screening everybody, so far anyway, hasn't proven to be very successful. But if we can identify the women who actually have risk factors, that may improve the screening for those who need it. So selective screening may be the answer. So if we look at these risk factors, if we take no risk factors at all as a risk of 1, you just have your multiples of that risk. If we see if you've got one relative who's first or second degree, so a sister or a mother with ovarian cancer, your relative risk goes up by 3 times. If you have 2, it goes up to about 5 times. But if you're on the pill, it drops down by 1/3. If you've had a baby, it drops down by half. If you have infertility, it goes back up. If you've never had a baby, it goes up. If you breastfeed, it goes down. And that's because it suppresses your hormones. And it's something that we don't tell people about. That, you know, in addition to it being good for the baby, good for the mother, helping with bonding, all those good things, that actually can improve your risk of ovary cancer. Having your tubes tied decreases your risk of ovarian cancer. And having your tubes removed also does that. And that's led us to, that kind of idea has led to some recent research over the last few years where they found that they think that a pre-cancer change in the fallopian tubes may actually be the thing that causes ovarian cancer. And the reason they looked at that was because things like having a tubal ligation improved your risk of having an ovarian cancer. And they also found that the most common type of cells in an ovarian cancer aren't actually found in the normal ovary, but they are found in the tubes. So they think perhaps that a small pre-cancer change in the tubes ends up getting into the ovary when you ovulate, because the ovary bursts open to release the egg. And these little bits of pre-cancer changes may end up in the ovary and then become an ovarian cancer, even though the cells actually came from the tube. So what I recommend to people who are having a tubal ligation is that they actually have their tubes removed rather than just clipped. So if somebody's having a cesarean section, for example, we recommend that their tubes are fully removed to reduce their risk. And we think that may reduce their risk by about 1/4 or 1/3. So when we're doing hysterectomies, if we're leaving people's ovaries in because they're having hysterectomies, say for heavy periods, then we recommend taking the tubes out as well. And indeed in British Columbia, which is a very well-run cancer program, they recommend that for all gynecologists to inform their patients of that as a benefit. So going back to the screening, there's been a few big trials, and when we talk about screening, you have to screen a lot of people to get an answer, because you want to look at a small benefit for the individual, but a big benefit for the population. So there's the PLCO trial, and the O stands for ovary, and they looked at 80,000 women in the US, and they did an ultrasound and a CA125 versus just coming if you had a problem, and they didn't find any issues. But they did find that out of the 1,000 or so people who ended up having an operation because of an abnormal screening test, that didn't turn out to be anything sinister, 163 of them ended up having a complication from their surgery. So there is a risk involved with having screening if it doesn't work. This is the big trial that we're waiting on, the UK TOX trial. So it's the United Kingdom Trial of Ovarian Cancer Screening. And they've looked at a huge number of women in the UK, and they are going to release their data probably next year to see whether, to kind of really, this is the big trial that we're all kind of waiting on to see, does this answer our question about screening. So they split it up into 3 groups. 100,000 of the women just went to their GP if they had a problem. 50,000 had an ultrasound scan, and 50,000 had a CA125 and an ultrasound scan if there was a problem. And that's called multimodal screening, or MMS. So they found the specificity and the positive predictive value, which are statistical terms saying how good is the test, were higher with the multimodal screening. And they found that the ability to say whether there was a problem accurately was still pretty good in both groups who had a test. So essentially the final results have to be looked at, because you have to add up an awful lot of bits of information if you're looking at 200,000 people. So that hopefully will come out next year. And that'll give us an answer about whether we should be looking at actually screening people like we do for cervical cancer or for breast cancer. There's a Japanese trial, similar thing. They found that they found slightly more early disease in the people who had the scans, but they didn't see a big difference in the overall success rates in the patients who were diagnosed. So we talk about our tumor markers. As Una mentioned, our CA125. That's the most common marker that's raised. It's raised in what we call serous cancers. Serous cancers are cancers that secrete the fluid, that the cells secrete fluid. There are other kinds of tumor cells in ovarian cancer, but the most common one that's raised is CA125. Now, if it's up, it's great, because if you know it's up, it's bad, and you know it's down, it's good, so that if you've had a high level and you've been treated and it's remaining low, it's a good way of keeping an eye on things without having to do ultrasounds and scans unnecessarily. The problem is that it's raised in a whole pile of other things. So endometriosis, fibroids, liver disease, pelvic inflammatory disease, and all, other cancers, and anything that causes fluid in your tummy can cause it to be raised. It's lower in smokers and non-whites. And as a single test, it's actually not that good at telling you whether there's a problem. So just having a CA125 as part of your routine blood test when you go to your GP every year probably isn't that beneficial. It's got an average of what we call a positive predictive value of 3%. So that means you have to do 30 examinations to find one cancer. So if you have somebody with an abnormal CA125 just on one test, you have to do 30 ultrasound scans or 30 biopsies to find the one cancer. So it means a lot of work and a lot of potential harm for those other people before you find the one person with a cancer. So what this is the same doctor who reported who's doing the UK tox trial, and what they do is a thing called an ROC algorithm, which is just a fancy statistical way of figuring out how to use your CA125 appropriately. And that's increased the positive predictive value to 19%. So that means you only need to do 5 tests to get one problem, which is a much better pickup. And hopefully that'll give us the more information when that comes in next year. There are other markers which we used, and one of the newer ones is called HE4, which the FDA in the US have approved for surveillance of cancer, that you can use it as a tumor marker to add to the accuracy of testing for CA125. But it hasn't been approved for screening yet. And the thing that is probably most beneficial for its use for general gynecology is that if your CA125 is up because of a benign reason, your HE4 often isn't. So if you do the 2 tests, you can tell whether someone with a slightly raised CA125 has a bad chance of it being cancerous or not. So anyway, the genetic syndromes. The main ones that we have are BRCA1 and 2. So these are genetic abnormalities that much increase your risk of having ovarian cancer as well as other types of cancer. And that probably accounts for about maybe 10% of all the people who have ovary cancer will have these genetic syndromes. So BRCA stands for breast cancer, and there's a group 1 and group 2. And these are a bunch of genetic abnormalities on your DNA which affect the healing ability of your DNA. So your DNA breaks apart and splits and repairs itself very frequently in order to tell your cells what to do. So if the repair mechanisms for that are wrong and don't function properly, abnormalities creep in earlier, and the DNA becomes corrupted and it leads to cancer change. Specifically in BRCA, breast and ovarian cancer. So it's inherited by what we call autosomal dominant inheritance. So you have a 50-50 chance of getting it if you have one parent who has it, another parent who doesn't have it. You have a 50-50 chance of getting it off the parent who has it. And what it does is it increases your lifetime risk of breast cancer and of ovary cancer to much higher levels than the average. And how do we kind of pick people out who are like this, who may have this? They have a lot of family members, sisters, mothers, who have breast cancer. They have male breast cancer, which is very, very rare, a young age diagnosis, and breast and ovary cancer in the same family group. And these are people who should have genetic testing, because there is actually something you can do to prevent ovarian cancer in these patients, which is to take out their ovaries when they're finished using them. And that will reduce their risk of ovary cancer from being very high to back down to being very low. There's another syndrome called Lynch Syndrome, which is mainly a bowel cancer syndrome, as is understood by most people, but it also increases your risk of ovary and womb cancer. And the reason it's considered a surgical syndrome, and the general surgeons see it a lot more than we do, is because Mr. Lynch, who was a surgeon, had an Irish maid called Mary, as they all are, who he found one day weeping on the back stairs in the scullery, and he asked her what was wrong with her, and she said, "Well, all of my family are dying from cancer. This is back in the early 20th century, and all of my family die of cancer. They all died at a very young age." And he, of course, being a surgeon and a smart fella, decided to look into it. So he took a family history, and he found that all the men got bowel cancer, and a lot of the women got womb cancer and bowel cancer. Now, because he was a surgeon, he disregarded the womb cancer and the ovary cancer completely, and looked into the bowel cancer. And we found that, again, it's a syndrome where your repair mechanisms don't function very well, and abnormalities creep in to how the cells work, and then they increase the risk of these. So the risk of ovary cancer here is about 10 to 15%, but it's actually the risk of womb cancer for women is much higher. So in these high-risk people, what can we do? There's been several trials to look at this, but they still haven't found a very good way of testing using ultrasound scan. And the problem is that an ultrasound scan will tell you why things look like today, but they won't tell you what they look like in 6 weeks or in 3 or 4 months. So even though people were being screened every 6 months, they were still finding abnormalities appearing between the two tests. So what can we do? Well, we recommend that people have a BSO, which is Bilateral Salpingo-Oophorectomy, or removal of the ovaries. And that we recommend that people consider that after the age of 35 when they're finished their family. And it reduces the risk of breast cancer because the ovaries don't stimulate the breasts if they're not there. We know that we can replace people's hormones with a small dose of hormone replacement therapy, and it doesn't seem to make a big difference to their risk of breast cancer, and that they can then have their breast cancer kept under surveillance until such time as they want to have breast cancer surgery. We know that using the pill reduces your risk of ovary cancer for everybody. It also works for people who are at high risk. So how do we look at, if we have a concern about somebody with ovary cancer, how do we investigate it? Well, the easiest one to access usually is a pelvic ultrasound scan. We do have problems in Ireland with public access for ultrasound scan. And again, this comes down to lack of money and the HSE not having facilities and so forth and so on. And a CT scan is a more expensive way of investigating a mass in the pelvis. But generally, an ultrasound scan, if it's available, is relatively quick. It doesn't involve any radiation because it's ultrasound, which is sound waves, and it allows us to investigate the ovaries fairly directly. We can also do our blood tests. CA 19.9 and CEA are other tumor markers that we can look at. We know that 80% of women with ovary cancer have a raised CA125, so we can use that to monitor things. So our initial investigation and our follow-up investigations often include CA125 and a CT scan. So how do we diagnose it? Well, one of my old bosses was very pithy, and he used to say, tissue is the issue and cancer is the answer. So we have to take a biopsy of some description. But we don't necessarily want to take a biopsy out of the ovaries prior to removing them, because that may allow the cancer to spread. If we have a scan that shows a pelvic mass but it's not anywhere else, there is a chance that having removed that intact, that the patient no longer has any cancer cells left in the body, or a very minimal risk of that. So sometimes we proceed directly to surgery prior to getting a diagnosis on the assumption that an abnormal appearing ovary is cancerous until proven otherwise. So that's, we talk about open surgery, which is laparotomy, which is a cut in your tummy. Laparoscopy, which is keyhole surgery, and that may be more appropriate in early small ovaries that may not have a high risk of spreading, that we can get at them through keyhole surgery. But if it's spread and it's already in other parts of the belly, such as on the omentum, the fat that hangs off your bowel and your stomach, or on the liver, then we can take a biopsy of those to confirm what's there. So when we talk about laparotomies, we've got, like a C-section, we've got a transverse incision, but we tend not to use that very much in cancer surgery. And the reason being that if we have a problem up here in the top half of your tummy, we want to be able to go up, whereas if you make a cut up here, we can't get at it. So generally, people who have open surgery have a vertical incision or a midline incision. So if we talk about primary surgery, we have a lump. We want to get in and we want to do something about it. We call this debulking surgery. We want to take the bulk of the abnormality out. Everything must go as much as we can get at. So generally, if we know that it is a definite chance that this is going to be cancerous, it's best done by gynae cancer specialists. And primarily because we're trained to operate on other parts of the body in the pelvis and in the abdomen, such as the bowels, such as taking biopsies from the liver and the stomach and removing the spleen, for example. And when we would talk about the best effort we can do to get this out, we talk about optimum debulking. And if we leave nothing visible behind, it's better than 0.5 centimetre of stuff left behind. That's better than a centimetre of stuff left behind, and that's better than anything else. Now we can talk about a centimetre, and there could be several bits of 1 centimetre, or several bits of half a centimetre. But if we have one bit of 10 centimetres, we're leaving it too much behind, okay? So why is that useful? Because it's been shown that the less you have inside after the surgery, the lower the risk of the chemotherapy not working. Because if there's less to treat, there's 2 issues there. There's actually less bulk of cancer cells to treat, and there's a lower risk that some of those cancer cells won't react to the chemotherapy. So this is just a graph from a study which showed if you have less tumor, you do better than if you have more tumor. And there's a lot of graphs that show this difference between the 2. So the other name for this is cytoreduction, which is taking out all the abnormal cells. So we know that we get better results with the chemotherapy if there's nothing excess left to treat. And some of the reasons for that is that if you have a large lump in your tummy, a lot of the cells aren't doing anything. They're abnormal, but they're just sitting there and they're kind of not reproducing and they're just inert and there's a big lump of stuff. So the chemotherapy isn't always useful to treat those because they don't react to the chemotherapy because they're not going through any kind of function. So the chemotherapy can't interrupt their function. Big tumours have less blood supply in the centre, so there's bits within the middle that just don't get treated as well. And there's an increased risk of having resistant clones or cells that just don't react well to the chemotherapy. We also know that people tend to do better if you take out the big lumps. If you have a lot of tumour in your tummy, you have more chance of having ascites, fluid, you have more chance of having pressure on the bowel, you have more chance of having other difficulties like we discussed earlier on with the symptoms. And that means that people who get a good result from their surgery come out of their surgery hopefully better able to deal with the burdens of their chemotherapy. And chemically, there's substances called cytokines which are kind of inflammatory chemicals which are released by cancer cells in inappropriate levels, which can affect your immune system, and that has an effect on how well you do with your chemotherapy. So when we talk about a maximal surgical effort, we want to get everything down to no visible level, and this is where the gynae cancer surgeon comes in. We may have to remove a piece of the bowel, and that can be your large bowel, which is your colon, or it could be your small bowel. Small bowel goes from your stomach to your appendix, and that absorbs your food. Your large bowel goes from your appendix around in a kind of a big question mark down to your back passage, and that absorbs fluid from the waste products that are left after it goes through your small bowel. So they do 2 different things, but if they're involved, taking a piece out is usually preferable than leaving a bit on the bowel, because effectively you're leaving a bit that may still misbehave regardless of what else you've removed. That can lead to a surgical procedure called a posterior exaggeration, which we take the womb, the ovarian lumps, the blood vessels, and a piece of the bowel all out in one big piece. Now I spared you the photographs. I emailed Sharon about this, but I thought I'd leave the medical photographs to the medical talks rather than that, so I kept it to just the little pictures. Some people may need their spleen removed, part of their liver taken away, and they may need part of their stomach removed. Stomas are bags that allow the contents of the bowel to come out to the front of the tummy. And sometimes if we do have to take out some of your bowel, in order to protect where that has been treated and put back together, we bring out a stoma somewhere else. And hopefully that turns out to be temporary, to allow the chemo to have its full effect, but lessen the risk of leakage where the bowel has been put back together. So in all of this, we have to strike a balance. If you have very aggressive surgery, your risk of problems from the surgery, which is what we term morbidity, is higher. Your risk of death from having a surgery can be high too. So if you're a 95-year-old with an ovarian cancer, you're not going to be treated as aggressively perhaps as someone who's 45 who has an ovarian cancer, because your ability to handle that treatment, it may not be as good. People sometimes have to go to the intensive care, and that has risks as well. If we're very, very aggressive with the surgery and the patient becomes very ill after the surgery, sometimes they may not do well with they may have to delay their chemotherapy. And that may not be in their best interest, because we know that the combined treatment between chemotherapy and surgery is what makes people well after their initial presentation. That leads us on to, and I'm not going to talk about this very much because Sylvie is going to talk about chemotherapy, but neoadjuvant chemotherapy is chemotherapy before you have your surgery. Now, we know that doing the surgery is beneficial, and there are some people who would say that doing the surgery up front regardless is the best way to attack things. But there's been some evidence recently, some large trials have come to light in the last year or two, which have shown that giving the chemotherapy first, or giving some of the chemotherapy first, doesn't give you a worse outcome than doing the surgery at the start. And that may improve the chance that you get all the lumps out, because it'll clean up the stuff that's going to respond quickly, leaving behind the stuff that may not respond, and that is lessened in size, so it's easier to take away. It may reduce the need for example, breast or bowel surgery. It may reduce the risk of having to have a stoma. We can use it to treat people who are not well enough to have a surgery at their first presentation. And it also, in people who have stage 4 disease, where it has spread outside of the belly into the chest or the liver, we can assess how well they're going to respond. If they respond well, then it's worthwhile considering surgery for whatever it doesn't get affected by the chemotherapy. So, these are the trials I was talking about. So there was 21 studies looked at, and they found that your chance of getting all the lumps and bumps out is better, and it didn't make any difference in how well or badly you did. These are the two big trials, the EORTC and the CHORUS trial, and they found that the difference was in progression-free survival and overall survival, which is the two ways we measure how well a treatment works, didn't have any major differences. But there were lower rates of complications in the patients who had neoadjuvant chemotherapy. So sometimes it is beneficial. Now, sometimes we have to go back and do surgery after people have had chemotherapy for various reasons. And we consider this generally to be palliative in nature, not curative. So it helps you feel better. It reduces the amount of abnormalities that are there, but it may not actually extend your life or cure you of your disease. But it may make you better at having the treatments that you need to have. So who are the people who we would reoperate on? Are people who've been well for at least 12 months before having a problem, who may be able to have that second surgery and have all of what's there removed in the second circumstance. And that's often not feasible because of multiple sites of recurrence. They have to have done well in their first line treatment, and they have to be relatively fit, and it should be a locally recurrent abnormality without a lot of ascites. Sometimes we do surgery on the liver. The main reason for doing secondary surgeries is in people who have bowel obstructions. So people present with a blockage in their bowel. It often won't resolve itself if it's being caused by ovarian cancer. And sometimes it's a mechanical thing. There's scar tissue from previous chemotherapy or surgery. The bowel gets bent around on itself and pinched off, or else the mesentery, which is the blood supply to the bowel, gets involved and it blocks off the blood supply to the bowel and makes it unhealthy. So that's where there are different roles for that. In surgery for bowel obstruction tends to be kept back for the last resort, because people tend not to do very well following it. We can usually fix the problem, but a lot of people get very sick, and some people unfortunately pass away from the surgery, and if it has to happen, people generally tend to be in a very bad state of affairs, so we try and avoid it. When we talk about that, we talk about, if we're going to do that, we're talking about balance and whether the balance is there for people to have a good response to having the surgery, or should their symptoms be managed conservatively. And that's the other things that can be done. So I'll wrap it up. I'll take some questions after.